Hi, everyone. I am really happy to be here today chairing this panel. This is the second panel of our international seminar that is organized by Interleague Black, which is the International Network for Transport Inequalities in Low-Income Communities. Particularly, we are focused on the Latin American chapter, but we have in this seminar, we have been opening a little bit like this idea of understanding accessibility and mobility in the global south and making more or engaging with a more comparative approach to the research of these issues. The seminar, Citizens on the Move, focuses on accessibility and mobility. And this specific panel focuses on how we measure accessibility and the equitable access to resources, places, and opportunities in urban areas. Today we have with us Kate Lowe, which is a professor, which is part of the University of Illinois at Chicago. She's going to be our commentator for the panel. She studies transportation at the intersection of policy, funding, and mobility justice. Her work examines how varied stakeholders and transportation policies interact across different levels of government and how this impacts transportation investments and racial inequity. She also conducts qualitative research on lived experiences of mobility and accessibility for low-income population and Black and Brown communities. She's received a PhD in City and Regional Planning from Cornell University, a Master's of Art in Community Development and Planning from Clark University, holds a Bachelor in Cultural Anthropology from Bard College. Kate, thank you so much for joining us today in this panel to be the commentator of the 4 papers we are going to be listening today. So today, our first speaker is going to be Tamara Kerzhner from the University of California, Berkeley. Sorry, Tamara, if I mispronounced your last name. And she's going to be presenting a paper on connecting to health and education, assessing the accessibility provided by public transport in major African cities. So I will give Tamara the floor now so she can start the presentation.
Awesome. Thank you so much. Let me see if we can share a screen. And no. Here we go. Hopefully this is working. So thank you so much for having me. This is really exciting and not my usual forum. Usually I work on sort of the African and Middle Eastern issues, which is also this paper, which grew out of a project at the World Bank on looking at connectivity across African cities, particularly focused on what we're sort of calling human capital, coming at it really from a kind of human rights and access to opportunities approach. So the focus here was on education and healthcare services, which we've operationalized a little bit crudely, but we're sort of working with new data sets that are coming online. Sorry. Anyway, so this is a little bit preliminary, but kind of taking a first stab at trying to analyze connectivity across these swaths of African cities and trying to see what we can learn specifically about the role of public transport and land use in those cities. So I probably don't need to go too deeply into why we need good transport and good access to things, but just in terms of a very, very brief summary of the available literature on African cities, we can see that chronic illnesses, managing of sort of long-term health conditions, and as well as short-term emergencies is really impacted by distance and travel time and people's ability to reach a health clinic. So relatively more work has sort of been done on emergencies, like how fast, if you're in an accident, if you're having a heart attack, how fast can you get to a hospital? But we're also actually seeing really, really bad long-term outcomes on things like managing HIV, managing chemotherapy, managing diabetes. So these like long-term chronic health conditions where people are just skipping life-saving appointments that they need a certain continuity of care of. And that's not even to get into questions of things like preventative health and small scale things, which I don't think even have very good data on. The same case with education where the research is sort of empirical research is even more limited, but we can see that we have some studies that show that students that are living further from school and have a longer commute to school completely intuitively do worse, and that is the impact is worse for those that are sort of already starting out as weaker students, coming from lower income families, et cetera. Again, kind of very intuitive logic here. So this particular study, we had data across 11 cities in sub-Saharan Africa. We didn't quite manage to have all the data for all the cities, but we had a pretty decent sample of it. So we had the location of primary and secondary schools and of what we're calling advanced health facilities. So those are really hospitals and sort of major clinics. It doesn't just have to be like a major hospital, but somewhere that offers like advanced maternal care, surgical care. So not your sort of neighborhood GP or nurse, but something that's sort of a higher level. And we have that both for private and public across the swath of African cities that was collected by like a whole lot of different teams across the World Bank, working with governments, working with different mapping projects. And we got this pretty good geolocated data set for all these different cities. So just to summarize this a little bit, these are the distances city by city. This is a different study, city by city on the travel time to the nearest health facility, sort of major health facility. And that goes from 5 minutes in the car to close to an hour in Luanda. But when you look at the lowest quintile, almost everywhere, right, it's significantly higher. So there's a relationship here between where things are located, what kind of transport people has, and where vulnerable groups and lower income populations are located across cities. So it's not like this study was able to disentangle all of this and give us a perfect model, but we started to kind of take a stab at it. So just to talk a little bit about transportation in African cities, and maybe particularly for those coming from sort of the Latin American context, there's a lot of similarities, a lot of informal transport that is primarily these privately owned small vehicles. But I think an important point about sub-Saharan Africa, when I compare that to the Latin American literature, is that this is really, really dominant. And across most of these cities, the only form of available transportation. This is not complementary to anything. It's not filling any niches. It's not offering an extra layer of accessibility. This is it. So we're talking tens of thousands of small vehicles operating across most cities. That same structure of like an independent owner working on the target system where the driver and conductor lease the vehicle daily and have to meet this daily payment. It's really highly atomized, which I think is important when we're thinking about kind of mechanisms of response and ability to serve different populations across the city, because even if somebody owns several vehicles, those vehicles are atomized. They're not pooled in any way. So each one of those vehicles is leased out to an individual driver, and those are all separate businesses. So each of them kind of has to make ends meet and has to like build up its own customer base on an independent basis with often very shaky cooperation that's kind of happening at a different layer. It's very limited barriers to entry. These are kind of a relatively popular way for middle-class individuals to have like an extra stream of income because they will just buy this vehicle, set it on the road. Nobody's really regulating entry across virtually any city. So nobody's checking like, do we have enough buses? Do we not? Do we have too many? And for the purposes of this paper, what's really interesting here is that there's really no proactive regulation from cities and governments on where these go, what the routes are, what the stops are. This is completely internally decided based on, well, it's a good question what it's based on. A lot of my dissertation looks at that. And axiomatically, we sort of assume it responds to passenger demand, but how that's actually processed and what passenger demand is and what, and is this like a single homogeneous category of passenger demand, or are we seeing that there are gaps in services? So a lot of the work that's been done in the past has looked particularly at access to jobs. And obviously we have better data on formal jobs than on informal jobs. So bringing in this layer of thinking specifically about health services and specifically about education, I think captures a different type of mobility and a different subset of the population. And are we seeing, does response to demand capture them as well as it does responsiveness to people going to work in the morning? So just to give a sense, we also collected for transportation data, which is to say paratransit data for all of these cities. Some of that existed from different projects, and some of this was commissioned specifically for this study to actually go out, map these routes, count these minibuses. That was done by different projects and different teams across these different cities. This is Djibouti, which is not actually in this project, but I sort of wanted to illustrate what the data collection here looks like and what it looks like to map out these kind of routes. So literally this was done by standing at a bus terminal with a clipboard with a group of students from the university and just counting how many buses are going per hour. So we have some sense of frequency, and taking them, with these phone trackers to the end of the route and collecting this data set, which was then turned into a GTFS that we used for the data analysis. So that's kind of our method. The data analysis is done mostly in ArcGIS's Network Analyst and in R5R, the multimodal routing package to calculate these various accessibility and travel time metrics, and as well as these obvious questions of like, so how long does it take? So who has access, who doesn't? We really wanted to add to this element of the land use. So also looking not just at who can reach what, but also how these facilities are located vis-a-vis the transport system. So is it that people aren't accessible, or is it that hospitals aren't accessible, sort of? And then what is the actual value added of public transportation? Because sometimes even if we see very long transit times, maybe because frequencies are very low or routes are very circuitous or traffic is very bad, that's still saving people, like walking an hour to the hospital and taking a bus for an hour to the hospital. Two very, very different experiences, right? And that's still an increase in accessibility, even if we can't quite capture it in terms of time. So clearly this obviously has generated like a great deal of data and a great different maps and analyses. And what we're just trying to do in the paper is summarize sort of some of the trends and some of the patterns and some of the questions it raises, rather than give sort of like a very, sort of the endless appendices of reports. So also in the interest of time, I'll just go over sort of a few key findings and hopefully open it up to an interesting discussion. So just, these are kind of like our top line findings in terms of schools' relationship to public transportation. So this is an access, right? So across these cities, we found in most cities, schools are sort of co-located reasonably well with public transport routes at any rate, except we do see some exceptions like Ouagadougou and Conakry. And we'll talk quite a bit about Ouagadougou because it has a particularly poor transport system, which sort of illustrates a few things about, let's sort of compare to cities that have a better one and what the added value there is. And with advanced healthcare facilities, so again, we're talking like semi-major and semi-major hospitals and big major clinics, they're quite well located, right? They are almost always in these kind of relatively central hubs or locations, and they have public transport services somewhere in their general vicinity at least. And then if we look at population density as well in relationship to this, most people in most cities are within a kilometer of a public transport route of some kind of quality. And this is kind of almost regardless of the population density across the city. We see that in like very dense cities, we see that in quite highly dispersed cities. There are, again, a few exceptions like Ouagadougou and Conakry. Just in terms of what that looks like, how we map this out, here's two examples of cities that are sort of in the better category, where we really see that the public transport routes here, the network, first of all, is quite dense. And secondly, it quite closely follows sort of the population distribution across the city. And then if we look at cities where it's not great, here's Ouagadougou, this network is not particularly dense for the size of the city. And then it doesn't really, it's based on this much older formal network that goes back to the colonial period, as far as we can tell. And it's not really changed as much as it needed to over time. And so you see these like huge swaths of the city. And if you look at the scale, these are like 5, 6, 10 kilometer walks for these like very densely populated areas to get anywhere within a public transport route. And we see some of that same pattern in Conakry, despite being this kind of narrow peninsula. Public transport routes are serving the more sort of historical downtown areas where there's a lot of commerce and business, and these like large areas where like many people actually live are getting this quite patchy service really. So that's kind of the examples of how we map this out and where we drew those indicators from. Here's how we position facilities. So for example, here's primary and secondary schools in Bamako. This would be Bamako, and we see, again, like overlaid with population density, quite sensibly schools are sort of distributed where people live. And then we calculate just the travel time using walking plus public transport services, kind of a pretty clear analysis. In this case, it looks pretty good. Mostly where people are living, they're living close to schools, and their travel times are fairly reasonable. And the locations where we see very high travel times are locations where population is quite low density, which is what you would hopefully expect. Again, this one is for advanced healthcare facilities looking in Douala. and Harare, sorry, which are slightly similarly shaped, so I'm always confusing them. But so we can see, and this is also a slightly different scale, Douala is much better. So most people in Douala, which is a smaller city, are kind of closely located to at least one major health facility. And in Harare, which is just much bigger, we see that those distances go. The distances to cover are much bigger, despite a pretty good kind of dense transit network, and travel times are just that much longer, and health facilities are fewer and far between. So just kind of our top line summary findings on this. School access is not bad. It goes from both primary and secondary from about 8 minutes to 27 minutes at the worst in Harare of travel time to secondary school. For advanced healthcare facilities, the situation is very much more variable and much worse. Some cities are doing pretty well, Kampala, Douala, even Nairobi. But then other cities are doing much worse, over 30 minutes in Bamako, Harare, Ouagadougou to reach the nearest advanced health facility. And this is a distinction we made between locations in the city and people in the city. So it lets us see, obviously, people are clustered in ways across the city, the space of the city, that makes the average person have better access than the average like plot of land. So it was another effort to kind of get at issues of land use and population density and how they're located vis-a-vis facilities and the transport network. Inequality matters. We see city after city, the poorest neighborhoods have fewer services located in them and worse travel outcomes. So the transport network isn't managing to bridge that gap and provide strong connectivity for people who are coming from poor neighborhoods, don't have those facilities at home, and they're not really able to reach them terribly conveniently. Like the gaps are definitely opening up here across multiple cities. One way we kind of tried to visualize this is what % of the population has access to a facility. So sort of the flatter this line is and the higher it is, the better it's doing. So here we can see that Kampala is kind of doing the best in terms of most of the population has good access to almost 100% of people at 30 minutes of travel time are able to reach a hospital. And also it's quite equitable. And if we look at the bottom line, the Ouagadougou, it's both poor, even at 60 minutes, there's like a decent chunk of the population that aren't getting there. And that long slope of the line means that it's also very unequally distributed. This is kind of tricky to visualize, and we've been playing with it in different ways. This is, for some cities, not for all cities, we were able to distinguish private and public schools and private and public health facilities. So we can also see the gaps, and in this case, private is better. So there's more private schools and they're located better for access, and the people who are reliant on public schools have that much harder a time reaching them across both these cities, right? Yes, Conakry and Ouagadougou. So another thing we looked at across several cities where we were able to was this the question of like the added value of public transport. So what we did in Ouagadougou, for example, this was access to secondary schools, which unlike primary schools, in some cases, kids do travel by public transport to them. So you might go half an hour to get to their secondary school, whereas primary schools are overwhelmingly closely located within neighborhoods. And if we look at Ouagadougou and we compare, what if there was no public transport? What if people just had to walk? And we compare that to the actual existing public transport network, it gives us almost nothing. So we looked at the amount of the trip that was actually spent on public transport, and in Ouagadougou, virtually everywhere, it's nil. You get no benefit from waiting for the bus rather than just walking. Whereas in Harare, in Bamako, we actually see there's, not in the central areas, but some of these like quite large swaths of more peripheral locations in the city, people do take a bus, or at least they're able to theoretically take a bus based on the data we have, and that does shorten their trip substantially. Like a big chunk of the trip is in a vehicle, and that is making it shorter and making something more accessible. So that speaks to sort of the role of the public transport network here and actually providing useful access. So that's sort of the different analyses that we ran for the different cities. This is just kind of a snapshot of some of the approaches that we took to try and kind of untangle these questions. So some brief sort of preliminary observations, as you can see, between 8 and 27 minutes, not too bad. Primary, they're doing better than secondary. This is mostly facilitated by walking. This is facilitated by schools being well distributed. Most people in most cities can walk to a school, And almost all people in almost all cities can walk to a secondary school. And that's why we're seeing these good access times. It is not because the public transport system is helping these kids get to school. So that's a limitation here and a gap, because walking time to your nearest school may be vastly insufficient way of actually capturing access to educational possibilities, right? We've seen this gap between the public and the private. The nearest school may be an expensive private one, or alternatively, a very, very poor quality public one. It depends on the cities. In different cities, the more accessible school and the better possibilities of education are often different between this public-private divide. The other thing we've seen is in some cities, there's girls' schools and boys' schools, particularly those run by parochial communities, Catholic communities, Muslim communities, and often those are the very good schools, but that means we've got to somehow disaggregate this between girls and boys to understand the accessibility. And then just like there's different schools, right? Even within the same neighborhood.
Sorry.
And we're running out of time.
Yeah. If you can close.
I'm wrapping up.
Okay, perfect.
Yeah. Yes, last slide. For health, much worse, between 8 minutes in some cities and 57 minutes in Ouagadougou, wide level of variance. And here it's because despite these health facilities being on the transport network isn't facilitating access to them, right? Like not everybody needs a school within a major hospital within 5 minutes walk, but you want to be able to reach it. So just to completely round this up, we're seeing these gaps in access that even though people live close to transport and hospitals are close to transport, that connectivity isn't there. Those transport networks are providing some other type of mobility, possibly. I would guess they're providing mobility to jobs, and they're providing mobility to like the downtown commercial employment centers. But these, and this becomes a gender question and a kind of mobility of care question. If you're somebody who needs to reach facilities, community, a hospital, errands, mobility, what we might call mobility of care, those networks are not helpful for you, even though at first glance they're sort of dense and well located. And obviously much more research needs to be done on this. And that's it. Thank you.
Thank you so much. And sorry to hurry you up, but
No,
thank you for just like wrapping up super fast. I want to continue. Just sorry, give me 1 second.
Let's see if I can stop
Yes.
share.
Thank you. Oh, sorry. Sorry. Okay, I got it here. So I'm gonna now introduce the second speaker. That is, sorry, lost it here. So Diego, who is also our host and was our chair in the previous panel. Diego is an associate professor in the Department of Social Science of the Universidad Católica de Uruguay. He's a sociologist with a master's degree in political science and a PhD in urban studies. He developed research in transport mobility, social inclusion, and equity in Latin America, including spatial accessibility, affordability, and gender mobility. His recent research work includes, among others, projects on healthcare accessibility for children in Montevideo from a time geography perspective and the effect of spatial accessibility by public transport on labor performance. He has published his research work in scientific journals and books published by reputed international editorial houses. He has worked as a consultant for national and international institutions. Diego's going to be talking about interurban accessibility to job opportunities in Uruguay. Diego, the floor is yours now.
Okay, thanks very much, Natalia. I'm very glad to be here. So I represent this work that was co-authored with my colleague Martin Hans on interurban accessibility. Well, regarding the program and objectives of the paper, it has to do with intercity accessibility by public transport. We are talking about accessibility between cities, not within cities. It's not urban mobility, but interurban mobility. So people have to travel from one city to another to get to the opportunity, reach the opportunity. This type of accessibility may produce specific patterns of mobility restrictions and vulnerabilities, especially for the Uruguayan case, in which you have very small cities with fewer opportunities, longer distances to overcome, worse transit provision, and low population densities. But we argue that intercity accessibility could also inform the debate on policies to enhance accessibility. So this paper seeks to analyze intercity job accessibility through public transport in small and middle-sized cities outside the capital of Uruguay, Montevideo, with two objectives: to understand for 5 regions in which we divide the country, to understand and describe intercity accessibility patterns in those regions, and to assess policy configurations that is demanded to remedy accessibility or to improve vulnerability based on accessibility. Basically, 2 types of measures: transport-based or territorial development or land use-based. But our conceptual references come from 2 sources. One that we all know very well here, the accessibility studies, where that define accessibility as the ability to overcome geographical distances, and this is a requirement to participate in necessary activities for social inclusion. And it posts that uneven accessibility produces urban and regional inequalities, and it also conceives accessibility as the combination of urban form, transport system, and individual attributes. This translates in several policy fields to change accessibility levels. You can either change the transport system or transport network or the urban form to enhance accessibility. However, in a specific context, transport network improvement might not be effective. From the second conceptual reference is its regional studies approach. In this case, regional studies approach to territorial development and generally stresses territorial capacities such as human capital or innovation potential. This literature conceives accessibility from an economic perspective. It's like an input to ensure the movement of persons and to increase economic output. It's also used accessibility to analyze regionalization. So to define regions, they use connectivity in order to compose regions. But is that not, they don't conceive accessibility as the same way we conceive it. So, and there is one very interesting distinction from regional studies that points out to 2 types of policies: broad versus narrow regional policies. The former refer to business and economic development measures. They are more integral measures that has to do with social and economic development. And the latter to government sector policies. They are sectorial policies that adopt regional programs such as transport, communication, education, and health. We could think about broad and narrow approaches for accessibility policies. So an empirical question arises: how to know when it is feasible to implement narrow regional policies such as transport-based ones to enhance accessibility? Transport-based, on the contrary, to adopt more integral ones, right? We argue that to inform this debate, it is necessary to study the dynamics of urban development and transport network. And this is now when we can talk about accessibility. See, we argue that the relation between accessibility at the individual level and at the city level is illustrative for this discussion. When we complement this relation between city level and individual level accessibility with some indicators, for instance, endogenous development potential, such as the capacity of a city to fulfill shock demand without recurring to opportunities outside its boundaries, we can get very important inputs to inform this discussion. So our methodology is to calculate cumulative work opportunities between urban agglomerations in Uruguay. It is outside Montevideo. Here is the universe of the cities that are considered. We compute a traditional Hansen accessibility index with a dichotomical impedance function with a threshold of 60 minutes. So accessibility is the number of job opportunities that you can reach traveling by public transport outside your city up to 60 minutes by public transport. We also compute a critical cities indicators. Critical cities have to meet two requirements. They have more economically active persons than job opportunities, and their accessibility level is below the first quartile of the distribution of the country. This is something less than 2,000 job opportunities. We develop a public transport network density indicator, that is the ratio of the length of the public transport network to the region area, and a public transport connectivity indicator that is equal to the number of cities with a public transport line that passes through them. With looking at the combination of these indicators, we can address the feasibility of adopting sectorial, namely transport-based measures to enhance accessibility. This is our universe, and here you see this discontinuity in accessibility. The blue dots are cities outside Montevideo metropolitan area, and here you have a jump in order change. This is accessibility to job opportunities. So here you can see that there are very different types of cities. So this is our universe, the blue ones. And here are the results that we get in the paper. In the left map, you can find the color dots indicates the number of job opportunities that you can reach traveling up to 60 minutes in public transport, and the size indicates the population of the cities. What you can find is not new for us. Bigger cities have better accessibility, of course, but it's also interesting to complement this data with some data on the distribution of accessibility when we calculate them place-based and we calculate them person-based. So place accessibility and person's accessibility, we have pretty different results. Here is the general mean of job opportunities reached from each city, and here is the mean of the accessibility index on average for each person. So we can say that from every city you can reach traveling up to 60 minutes by public transport to 15,600 job opportunities. But for the person level, on average, each individual could get almost 31,000 opportunities traveling by public transport up to 60 minutes. Of course, we could expect that because bigger cities have better accessibility and people tend to live in the cities where they can find the opportunities. But it's interesting to see some parts of the distribution, especially the lower 25%, the first quartile. The differences between place-based and person-based accessibility are different for each regions. Meanwhile, for every region, you have much higher accessibility index values. For some regions, the difference are much bigger. For instance, especially the northern regions, these are the one northwest and northeast regions, you have, and that increase, the ratio of increase is much higher. And you can see also the 20-20 ratio. This is the ratio of the 20% lower compared to the 20% higher of accessibility. And what you can find here is that for the Northwest region, the 20-20 ratio was almost 72. And when you calculate person-based accessibility, it shrinks to 3. And to some extent, it's similar, but much lower the difference, but it reduces from 15 to 5 for the Northeast city. So what we try to do is what we can find here is that the ratios behaves differently between regions. Here you have some box plots. We don't have time to describe every box plot for each region, but what you can find is that there is a big differences not only in the level of accessibility, but also in the distribution. So the importance is not only to see the change in the level of accessibility index, but also how it distributes for each region that difference and complement them with other indicators such as this. the public transport network density and the public transport connectivity, what we can find here is that the worst values for these indicators, you can find them in the same regions that you have the biggest differences between place-based and person-based accessibility, the Northwest and the Northeast. And the red dots are the critical cities. So it's not casual that we can find a lot of critical cities also in these regions.
Diego, 5 minutes left. 5 minutes left. 5.
Perfect. Thank you. I'm wrapping up. So here in this table, you can find the summary of our findings that combines all the indicators. What I was telling before, we should see not only to the absolute accessibility levels, but also the differences between person-based and place-based accessibility levels, but also the differences in the distribution. It is what we can find here. Here we have the absolute difference in the 2020 ratio, the absolute difference in the Gini index, the network density, the connectivity index, and the percentage of cities that are critical within that region. And what you find is that there are two regions that follow the same pattern for all the indicators. They have a very different pattern when you compare person-based to city-based accessibility, but they also have more critical cities. They also have a less dense network, and they also have less connectivity. In those cases, we argue that looking at the combination of these indicators, we can claim that these regions, in this region, is not feasible, or at least it won't be effective to adopt transport-based policies in order to enhance accessibility. To some extent, we can say, okay, you can increase. First, you have a worse transport network, but second, even if you improve that transport network, you can ask, well, where will you take that people? So to sum up, the analysis of accessibility suggests the existence of several small cities with great vulnerability in terms of accessibility. These are the bad news, but the good news is that this fact or this finding does not impact on people's accessibility because people live in more attractive cities in terms of opportunities, but we argue that it poses an important challenge for territorial and transport policies. Okay, people live in centralities, that's right, we already knew about that, but you have a lot of cities that basically has no activity at all. So they are ready to die, let's say. So what our contribution has to do with identifying these regions with very low levels of accessibility, low density settlements, very low endogenous job opportunities, more disconnected from the network than other cities in the region, with more critical cities. So for these regions that are the northern one, even when you may be able to improve public transport connectivity, it will not benefit a lot of people. This region's accessibility must be addressed with broad regional policies, since public transport ones will have a limited impact and they will be extremely expensive. So this analysis complements regional development ones. I think this is a way in which accessibility literature contributes to regional literature and regional studies literature, and it will be a great proxy to inform territorial policies and to diagnose development issues at the local level. So thank you very much.
Thank you, Diego. Our third presentation, our speaker will be Santiago Cardona from the Universidad Nacional de Colombia. Santiago is a civil engineer with a specialization in roads and transport and a master's degree in engineering, infrastructure and transport systems. all of them from the Universidad Nacional de Colombia. He's going to start his PhD program in Utrecht University this year. And he's a junior researcher from in the research group of sustainable mobility in the Universidad Nacional de Colombia. His research interests include sustainable mobility, accessibility, urban and transport planning, public transport, active and transport, and micromobility. Santiago is going to be talking about geographical accessibility in medium-sized Colombian cities. Santiago, the floor is yours.
Hi, good afternoon. Thank you for the invitation. I am going to share my screen. Okay. So here today I'm going to talk about geographic accessibility in medium-sized Colombian cities, considering private vehicle and cycling. This research was done with Diego Alexander Escobar and Carlos Alberto Moncada from National University in Colombia. At first, well, okay, we are going to talk about introduction, materials and methods, some preliminary results, and the first conclusion of the study. So at first, I would like to talk about the concept accessibility, that is the potential opportunities for interaction. Hansen in 1959 used the impedance and the desire to define this concept. Then in 1971, Ingram defined accessibility as the inherent characteristic of a place with respect to overcoming some form of spatially operating source of friction. Ingram introduced two concepts, relative accessibility, integral accessibility, and those concepts are so important for this investigation. Recently, Cui and Levinson in 2020 published an article called Unifying Access, and they unify a lot of concepts related to accessibility, and one of them is the geographical accessibility concept, that is a measure where the set of opportunities, so for example, you have a road network with a number of nodes, and the nodes are the opportunities, and you measure the average impedance from one node as an opportunity to all the other nodes. And that is the computation of the geographical accessibility measure that we are going to use in this research. So here we have a figure from Escobar and Garcia of 2012 that shows the difference between relative accessibility, integral accessibility, and geographical accessibility concept. The difference from the relative accessibility is that we have a connection from 2 points. In integral accessibility, we have a connection from 1 point to all other nodes in a network or the opportunities in a region. And the geographical accessibility concept is that is like the average of all the integral accessibility of one node as an opportunity in the region. So to conduct the research, we review until now 15 papers and research in Colombia. This research started maybe from 2012 and 2022 are based, most of them based in large cities like Bogota, Cali, Barranquilla, and the most common city, the most common cases to the city is Bogota. On the other hand, we have some kinds of accessibility measures, so like potential accessibility, cumulative opportunities measure that are the most common in those kind of studies. And as you can see, public transport is the most frequent mode of transport that the researchers calculate. In some cases, they compare public transport with car or bicycle with pedestrian or something like that. At this point, we want to do an investigation that measured the geographic accessibility in medium-sized Colombian cities, comparing private vehicle and cycling. we want to compare a difficult mode of transport like private vehicles that are polluted, congestion, and those kind of things in cities with cycling that is a good alternative for sustainable mobility. We are going to use open source software data and code like Python. So we are going to retrieve OpenStreetMap road network, and we are going to use access to Google Maps API. So we want to compare cities and modes of transport to promote a dialogue about accessibility challenge within medium-sized Colombian cities. So now we are going to talk about the materials and methods. First, we need to choose the cities. Then we need to calculate the geographical accessibility for private vehicles and cycling. And then we are going to build and propose some metrics indicators to compare the results. All this framework was done using open source data and programming language. So you can replicate in any context around the world. So at first we used the proposal for a school et al. In 2021 and the OECD ODE that they propose 3 kinds of cities in Colombia: small, medium, and large. We know that we have maybe 6 medium-sized cities in Colombia: Bucaramanga, Cartagena, Cúcuta, Ibagué, Manizales, and Pereira, and so that are going the cities that we are going to use in the research. Then we have the geographical accessibility framework. First, we need to obtain or retrieve the sociodemographic data, like the urban boundary. We are going to concentrate only in the urban environment, and we need the census data. And we use the Department Administrative of National Statistics for Colombia to retrieve this data. Then we need to obtain the road network from OSM, OpenStreetMaps. The speeds, we use the Google Distance Metric API. We use only the free limit sources. And we use Landsat data to calculate the altitude in the road network. Then we need to calculate the cycling speeds. We use Strava crowdsourcing data. We conduct a validation between road network model for driving and travel times for Google Maps in order to know if the model is like the real one, like the real world. And finally, we conduct the geographic accessibility calculation, the travel time metrics, the average travel time calculation, and we use QGIS to construct the isochronous curves using just statistical methods like rigging and so on. Finally, in the methods, we create some index and metrics like the isochronous curves, the population coverage, and we calculate the weighted geographical accessibility. So now we are going to talk about the preliminary results of the study. First, okay, we have the context of the cities. We obtained 6 medium-sized cities, Manizales, Pereira, and Ibagué, are located in the center of the country near to the Andes Mountains. So those cities have high altitude. And for example, we have Cartagena that is near to the Caribbean Ocean, sea, sorry, and they have a low altitude. On the other hand, these cities, 6 cities, reach more than 4.7 million of people. That is the 9% of the total population of Colombia. On the other hand, we have in here the number of links, the number of nodes of the road network. We compare cycling and driving. Cycling has the double of links and nodes than driving road network, and that is because cycling road network is bidirectional, and driving has some restrictions in to flow. With the Landsat data, we calculate the ascent and descent slopes. So we know that Manizales has the steeper terrain between all between those cities, so there is difficult to cycle, for example, in comparison with Cartagena that is flat. So now, yes.
Sorry, you have 5 minutes.
Okay, thank you. So now we calculate the speeds. We use the Google Maps API. We calculate 3,000 speeds per city because we don't to overpass the free sources of Google Maps. And we saw in the results that all the average speeds are quite similar within cities. And of course, we have that primary has higher speeds than, for example, tertiary roads or residential. We input these average speeds in all the network considering the topology. On the other hand, we compare and validate the models, and we use some index, for example, the mean square error, the root mean square error, and we calculate the Lagrange multiplier to check the heteroscedasticity in the residual plots of the data. We observe that only Manizales behave like a good model and is valid in the driving road network. So then we need to calculate the cycling speeds. We use more than 20,000 GPS points of cycling commutes in Manizales. We use Manizales because we have a steeper terrain, so we have a lot of different kind of slopes and groups of slopes. When the slope increase, of course the speed decrease. But for example, when you see the descent road network or the descent slopes or the negative slopes, we don't see differences in the average speed is quietly maybe 23 kilometers per hour. But when you start to climb, of course you observe differences in the average speed. Okay, so then we calculate the geographical accessibility and we calculate the isochronous curves of each city. We have differences in the shape of the curves, of the coverage curves of isochronous, because okay, we have differences between bidirectional, that is cycling, and restricted road network, that is driving. So that's different in the road network topology, produce differences in the curves. On the other hand, we have, of course, driving has better average travel times than cycling, but something is very particular, for example, in Cartagena, that the times or the average travel times are quite similar between both of the modes of transport. Now we calculate the population coverage. We see that, for example, in cycling, we have Manizales, Bucaramanga, Manizales, Cartagena, and Ibagué that are very, they have similar behavior in the coverage, and in driving they are very constant in the average travel times. And finally, we calculate the weighted geographical accessibility. We use to compute, we use population, area, housing, and sex. We don't see differences between these indicators in the same mode of transport and the city. They are similar, so we can use wherever we want. We don't found disparities in the geographical coverage between male and female. We know that there are differences, but we need to go in deep in other kind of measure to find it. But the very interesting thing, or the most interesting thing, is that we use the income levels. We have low income from 1, and the highest income is 6. So we found that, of course, like other investigations, that low income groups has the highest average travel times, so poor accessibility, and that is common for Bucaramanga, Cúcuta, Ibagué, Manizales, and Pereira. But the different result is for Cartagena, that Cartagena is the opposite. So the highest income groups of people have the highest average travel times. So the behavior of Cartagena is very particular in terms of geographical accessibility. And for example, when you compare the average travel times for driving and cycling, you can obtain a ratio of maybe 1. So they are quite similar. The times for driving and cycling are quite similar. In opposite, the other cities need to work more to promote cycling and to produce attractiveness to this mode of transport, because driving have higher average travel times and is better for accessibility in those cities.
Santiago, sorry, yeah, if
yes.
you can wrap up 2 minutes, please.
Yes, thank you. No, that is the last slide. Those are the conclusion. I am not going to read it. Thank you for the time, for the invitation. Those are the emails, and those are some of the references. Thank you.
Thank you so much, Santiago. Thank you for, like, you were giving us some findings. Like, thank you for presenting and finishing just on time. Finally, our last paper is about simple metrics and timely measurements to advance equitable accessibility to health services. And our speaker is Gabriel Cuervo from the Universidad Autónoma de Barcelona and the Amore project. Luis Gabriel is a clinical epidemiologist, family physician, public health professional, and a research policymaker. His career spans over 3 decades with a focus on bringing scientific evidence close to decision-making for health. He is part of a multidisciplinary and intersectoral team seeking to address the social determinants of health and advance the Sustainable Development Goals of the UN Agenda 2030. Luis Gabriel is the PI, principal investigator and leader of the Amore project, which provides dynamic assessment and accessibility with an equity perspective. The project seeks to influence land use and urban and health services planning. The project is part of Luis Gabriel's doctoral studies in the biomedical research methodology and public health at the Universidad Autónoma de Barcelona. And he leads a diverse multi-stakeholder international team with 3,000 volunteers who implement a test in Cali, Colombia. I will give the floor to Luis Gabriel to start his presentation, which is the final presentation of this panel.
Well, thank you very much, Natalia. I hope you can hear me all right. I'm very pleased to join this online seminar and discuss simple metrics and timely measurements to advance equitable accessibility to health services, the topic of the Amore project that I lead. Our project is completing a test case in Cali, Colombia. So we are sharing cities here with what the work that Santiago has done, for example. Let me, oops, slide's not moving, just a second. Okay. So 2 years ago, I began my doctoral project with support from my brother, Daniel, who's a data scientist, and Ciro Jaramillo, a civil engineer and professor in engineering and geomatics at the Universidad del Valle in Cali. And our project is now, as you said, an international multi-stakeholder and multi-sectoral collaboration. And here you see the names of some of the people that contributed to the protocol that we published of the project. I think anyone who's experienced being in a busy city knows that travel times can vary wildly. And it is common now that when we plan our day, when we organize our errands, we use our smartphones to know how long it's going to take to get to the place. Thus, I was wondering why, when we looked at projects to organize health services, we kept using Euclidean distances or travel distances or averages that can be misleading when it comes to health services planning. So for commercial things, we find that there's a tool that tells us how long it's going to take to get to a place. But when it came to the planning of social services, we're using a very different kind of information that probably was not as good. And I started inquiring, and I heard that dynamic assessments were unavailable, and they were when we started looking mostly in 2019 and 2020, and they were too expensive to be done. We wondered, what if we used existing data sources to get dynamic assessments and predict the potential impact of new services or schedules, or make recommendations. So despite being highly educated, I found that accessibility studies were quite sophisticated and difficult to interpret by non-specialists. And my experience in knowledge translation and of other people in the group and with intersectoral collaboration taught us that if the findings and the methods cannot be communicated to the relevant stakeholders, it is unlikely that they will impact policy, programs, and plans. So we engaged with groups of experts from different disciplines and walks of life, including authorities, service users and providers, academics, community leaders, to put forward a proposal to do a test case in urban Cali, a city with 2.26 million people in 2020. And it's Colombia's third largest city. And it's a place where I lived when I was doing my medical specialization, so a place that I would know and understand. Cali is considered the fifth most congested city in South America, according to this index that was published rather recently. And when we started exploring with people that are involved with the government in Cali, advisors to the mayor and to the secretaries of health and mobility, they were saying that the largest, the biggest challenge we have is equity and intersectorality. Those are the big challenges from their government perspective. Colombia has made great strides in digitizing and datafication. So we are able to obtain a lot of official registries, for example, for the health services and microdata of the census, as Santiago was showing, and as well as details of traffic analysis zones, and those are publicly available. And they provide a granular detail that is far better than traditional studies of mobility that we've seen there done there. We also identified several big data providers of travel times, and we picked one. So that's pretty much how we went about. In our experience, shared metrics and understanding are essential to get things, to get knowledge transfer to happen, and for the co-creation of knowledge. When you work with teams in which different stakeholders are involved, contribute to social appropriation of knowledge. And this is an example. These are contributors to one of the latest papers that we are preparing. And you can see it's a large team. We have over 2,000 people there, but the whole team contributing to the collaborative project is much more than this. This shows you the kind of audiences with whom we're working actually on the project. So you have people from operational governance, from constitutional governance and collective governance using this categorization proposed by Abimbola and collaborators. And we started working in using in the test case 3 case studies that fit into 2 scenarios. The first scenario is when you need when time is of essence, and we selected reaching a tertiary care emergency service in the shortest travel time. That is what you need when you have a complex life-threatening emergency where you need to have specialists involved and availability of a surgical room or intensive care unit, for example. So in those situations, you don't need to go to the nearest service. You need to go to the highly specialized service, which is what we're looking at here. And the second scenario, in that scenario, every minute counts. In the second scenario, we're looking into frequently used ambulatory services for high-cost diseases. Specifically, hemodialysis and radiotherapy is what we are looking into. People that are undergoing hemodialysis or radiotherapy travel to these services many times during the week, during the month and the week. And they usually have to do it with their relatives as well. And in Cali, usually people do this by car. So we picked one mode of transportation, but it can be done with several modes of transportation. They can easily incur into catastrophic health expenditures that sink families into poverty. Even when they have health insurance that covers the treatment, for most people, there's a substantial out-of-pocket cost and lost wages and missed job improvements. So it impacts families in a great way. In Cali, as you see here in the graph, half of the population, almost half of the population, lives in low-income housing. 40%, a little bit above it, lives in middle-income housing, and 9% of the population lives in high-income housing, including people that live there as maids or home care workers. So that gives you an idea of the population we're dealing with. And I'm going to provide an example that's grounded on reality. In Cali, people frequently use private or for hire cars to go to hemodialysis, as I was saying, and it's easy for the families to get stuck in poverty. And let's use this example to illustrate that. People that need hemodialysis because they have terminal renal failure have to go to treatment 3 times a week to survive, and at least around 5 times a week to feel well enough to feel productive and not have brain fog and things like that. So let's look at the costs of that. You can see on the map on the left how concentrated the services, the 11 services are. And the minimum income in Colombia is 1 million Colombian pesos. If you live in this area here, which is called, it was called Commune 19 because they're changing now names. That's a high income area. And a round trip would be about 10,000 Colombian pesos to the service. But if you live in this area here, it would be 70,000 pesos. But this is a low income housing area. So these people are paying more to get to the service. How does this impact them? Well, if you're going 3 times a week, which is the minimum, these people from here would be paying about 130,000 pesos a month, while the people here would be paying around a minimum income salary monthly. So there's a problem there. There's a huge difference, but also the issue is that the people here are the poorest people. So usually their families live with 1 or 2 minimum income wages, while the people here may have 4, 10 minimum income wages. So there's a big inequity there. And that is the issue. We need to look at who are the people and how are they being affected, because these people on Commune 21 have to make very tough choices. So this is the kind of information that we had. So we had the static maps, and we have, this is the best I found looking into this kind of things. This is looking specifically at the same example and shows the average times to reach the hospitals. And you can see here it says that the maximum would be 25, and it's a very small portion of the city. Most of the city could reach within 15 minutes, according to this. So we started wondering how we put the information together to see how the populations connect to the services, but also including an aspect of time during the journey. And we decided to look into existing data sources, as I was saying, because what we have currently is a static map. So it tells us the average, and we're looking at how most of the city would be able to reach within 15 minutes. But when we integrate all that data, which we did in a platform that's called the Amore platform, we find something like that looks more like a movie. So this is what you would find. And in this scenario, basically, as traffic builds up, you can see that the accessibility, which is at 85%, starts going down. So this is at 4 o'clock in the morning, 6 o'clock in the morning, and as traffic builds up, it gets worse. The most common traffic would be in Cali would be level 8, which covers most of the day, and we're getting there to level 8, and you see a huge difference. And the rush hour peak traffic is level 9, which is what we have here. So it's 37%, almost 37% of accessibility. But you can see the huge difference between the map to the right in terms of accessibility and the map to the left. So no way that you can make it in 15 minutes for the majority of the population, and that's one of our findings. But we go and delve into the population itself. For example, as Santiago was saying, here we have the income levels, with 1 being the people with the lowest income housing, because that's what we're looking at here, and the highest would be 6. And you see in July, we had a 37% accessibility roughly, that meant that these many people will be able to make it within 15 minutes, which is the threshold we are using here. And in November, there were traffic restrictions due to COVID. And you can see the difference that the COVID restrictions made for the people that were able to go out. That many more people, 500,000 more people were able to reach the hospital within 15 minutes. However, what you can see also is that there's huge differences in terms of economic income and accessibility, being as bad as regularly being about 8% for the lowest income people. Interestingly, we found also that the highest income people who live in villas in the outskirts of the city also have low accessibility, not as bad. It's much better than the other guys, but that's a finding that we were not expecting. And you can see when you go into other descriptors of this population, the differences also by, for example, educational level, which is of course tied to income, by having a disability, literacy, age, marital status, gender, or ethnic group, which is very important to see. And you can see how this varies as the traffic is completely changed. So we can get that kind of information and display it in ways that people understand it.
Please,
so
Gabriel.
Yes,
5 minutes?
I have 5 minutes. Thank you. So when you look at these maps and you are from Cali, you immediately know where your relatives or where you live or the people that you know live, and you know how bad it might be. Here you see for July, and it immediately tells us one story. Just looking at the image, you say, well, the services are far away from where the people live. The height of the columns here represent population density, and they correlate with economic stratum. So you can see that the people are far away from the services, and the poorest people are being left out. And the other thing we can do with the analysis is see how traffic congestion impacts on the different socioeconomic strata. And you see how the poorest, the lowest level of the incomes or the housing stratum are more affected by traffic congestion by far. So that's what the study shows. How does this relate to the existing frameworks? Well, if we look at frameworks on mobility, like yours, who is frequently cited, you can see that we have land use, like most of the assessments have land use. They have the transport component. They have the individual component, but we are adding one component. We're adding the temporal component, which makes it's essential so that we can have a real assessment here of accessibility to opportunities. There's actually an updated version of it published by his co-author Van Wee that is about to go out. Actually, it's a e-print ahead of publication. So you find the same components. He added the digital access here and made it simpler to understand. And it has the temporal component in our study. So it matches very nicely with these mobility frameworks. In the health sector, the frameworks talk about accessibility. They ask for assessing accessibility, but actually they don't even consider the indicators that are using the temporal component, and that's a big issue. And this is a series that came out in the Lancet in this year. It's an update of the 2016 series that they had with the same or very similar name. And we think that it's very important in this debate to push for the indicators of dynamic accessibility assessments to be considered in this framework. What's the way forward? And well, the way forward from our perspective is that we need to accurately measure dynamic accessibility with an equity perspective, co-create with stakeholders and data users, and engage advocates and advance the implementation of new indicators. We believe in integration within planning, monitoring, and evaluation of these kind of indicators, and to present options to optimize accessibility in the short and long term. Short term, I mean in this current government, for example, and the long term would be for several urban administrations. Identify areas needing investment. We saw, for example, in Cali that the eastern area is completely needing investment in services, and provide additional data layers, for example, kind of insurance that you have that would limit where you can get to, or finding the nearest available hemodialysis chair that's available at a certain time. replication, adaptation, and growth. And I'm wrapping up now just to tell you, well, this is what our project is about, providing new dimensions and data to integrate equity with urban and service planning. We have published an editorial that gives you the train of thought that we have with this project. We have a protocol that was published in 2021, a year ago, with the whole idea laid out. And we have a protocol for this year and the next one, which is narrower. And our results that were published, the first results that were published last week in the BMJ Open. And that's what our presentation is about. Thank you very much.
Thank you, Luis Gabriel. Thank you to all the 4 speakers. I think it has been really interesting. Just seeing like some topics that really start coming together about like questions, how we measure accessibility, how we use these measures to inform policy. I will leave the floor to Kate now. She's our commentator for her intervention.
Well, first of all, thank you so much for having me join this group. It's very exciting. I do a lot of qualitative and US-based research, so I'm coming at this from a different perspective, and I have to say I'm very inspired by the discussions going on in reframing accessibility. As I see these papers and the field really meaningfully embracing the idea that accessibility goes beyond the transport silo, and we really have to think about the provision of the distribution of opportunity sites and how mobility interacts. And what was exciting to me about all the papers and the title of today's session is a normative frame, is looking at accessibility with the frame that there should be equitable access to critical destinations. And all of the papers really ended with, what does this mean and what are implications and interventions? So I was excited to see the scholarship thinking through, yes, we need more knowledge, but we also want to engage in policy. I'm going to talk a little bit about some of the themes that came up across the papers rather than go paper by paper, and then I'll end with a couple of questions that I've seen others wrestle with and that I think touches on some of the work. I think some of the critical contributions that these papers make is in looking at these actual distributions of opportunities and jobs. I was glad to see Tamara's work look at both schools and healthcare, as obviously those are critical sites for well-being. And I thought it was really quite interesting how different the cities were and how schools and healthcare really vary. And that Luis Gabriel's paper on healthcare showed how different healthcare facility types also have different access, whether it's emergency access or ongoing care. And I think this attention to different types of destinations is critical. Job access, as Diego's paper looked at, is and will remain a critical area of studies within accessibility work, but broadening the scope is really exciting. I would love to see the field, if we had unlimited time and resources, think even further into the social goods like civic participation sites, as well as socialization sites, which are all part of enhancing well-being, which is ultimately what access to destinations helps us with, whether it's healthcare or education. I was excited that 2 of the papers looked at cities outside the largest. As Diego's paper reflected, there's often relatively stronger accessibility in the largest cities. And I think Santiago's paper referenced that it was looking at access for 4.7 million residents outside these largest cities. So how do we ensure that our work, while major cities, as some of the papers look at, will remain important sites of study and intervention, we can't overlook these other smart cities that present different complexities and problems. And what some of the work reflected is that different interventions are appropriate for different types of accessibility problems, and the papers helped unfold this a little bit. It may be provision of schools, it may be developing new healthcare facilities. It also may be enhancing public transit, but public transit interventions and enhancements are very complicated, and some of the early remarks about informal provision reflected. But Diego really brought us explicitly to this question of, is a transportation intervention effective? And I thought that was implicit in some of the other papers as well. Is a transportation intervention going to advance the cause of accessibility? Which I'll return to in my question for the panel. But one thing I wondered a bit with some of the papers is at what scale we were working at. I think this comparative look at accessibility helps illuminate that not all accessibility problems can be solved with the same intervention, but it's really hard to account for not only different national contexts, but different metropolitan contexts. So I appreciated in the last paper, we got deep into Cali, because I could imagine the city a little more. So I'm really curious about this challenge of how do we tell a national story or a multinational story, but still bring in the relevant contextual factors that make tremendous impacts in lived experiences of accessibility. And what I was kind of curious about, because there's all these barriers to knowing whether an opportunity site will actually meet the needs of a particular person. In healthcare, we heard about that. If there's not the right specialist, even if there's a clinic, it doesn't meet those needs. Tamara's paper talks about school types. It may not be it may be gender exclusive, it may be too costly. And I was curious, one of my questions for the panelists is, what is the biggest inequity that you think you need to look at next based on your research, or the biggest barrier that you weren't able to capture? And I'm also mindful of the idea of, we can't capture everything in a model, but do you have a hunch of something significant that you want policymakers or other researchers to look at? And then the second thing I'd like to hear about a little bit is this idea of transportation mitigating spatial inequities. We, as much as this research was intersectoral, which is very exciting, that's not always where the policy world is at. The policy world can often be quite siloed. So what messaging would you give people within a transportation policy silo of whether transportation can mitigate spatial inequities that contribute to inaccessibility? And I expect that's not a universal answer, so perhaps in what cases can it mitigate? But I really like a caution that's raised by someone presenting in another session, Tiznato Atkin, in a paper with co-authors from 2021, said, beware unintended consequences of transportation as a mitigation for spatial inequity because it might deepen. But I'm curious your thoughts of whether, how, and with what cautions could you direct a transportation siloed stakeholder to mitigate inequity, as well as just that hunch of what do we really need to know as a barrier in equity that was hard to capture or you'd like to. And with that, I'll give it back to the panelists.
Shoot.
Thank you. I'm sorry, I couldn't unmute myself. Thank you, Kate, for your intervention. I think it's really interesting. I also thought about like many questions about like mostly like how do you like address like differences between differences, to say it some way, and issues such as age, is that different? But I will give the floor to the panel. If you, I think it would be good to do it in the same order that we started. So Tamara, if you could start, yeah, to answer some of questions, some of Kate's questions, or all of them. It would be like good if we have like maybe maximum of 5 minutes per response. And if the audience wants to make a specific question, you can do it in the chat or after the presenters have speakers have gave their answer to the moderator, to the commentator. Thank you.
Wow, thank you for the kind of thoughtful response on that. I can't speak to all of it. I think to the question of sort of transport as mitigating spatial inequality, I mean, the answer is, as we all know, sometimes and not quite, and trying to sort of hang it all on transport is usually a recipe for failure. And I think sort of the positive thing to come out of this, the African cities analysis is, for example, primary schools, at least at the minimum, are well located, and we see that. But then obviously health facilities aren't. I think what I can speak to here is this context of informal transportation in particular. And I think what's important here maybe is not the informality, but it's market-based and it's unsubsidized. And there's a sort of, I would say, most of my work actually is also qualitative, and I would say there's a vein in the literature that assigns these kind of systems almost magic powers to overcome a lot of urban barriers, with no state subsidy, with this kind of, with no formal planning, with no data collection, this kind of preternatural, knowledge of the city that these drivers have because they're integrated into the community. And this is all true, but they're sort of being asked to perform miracles in a way. I mostly work with drivers and operators, and they are at the very, very margins of not even profitability, but survival. People here are operating in debt. Drivers are driving these vehicles while holding down other jobs off like during the week in order to be able to drive, because there's some like a hint of a possibility of social mobility there, which for 99% of them never pans out, but it still has that little bit more autonomy and prestige as some of the other jobs that they're doing. Anyway, not to get too deep into it, but I think this kind of like more fine-grained analysis is showing us these systems are absolutely crucial for a lot of things, but they're also not enough. And if they're not, and in a sense, this is almost a little bit of a low-hanging fruit, because we can see that there are places that have good connectivity, that have good interlocation with public transit routes, but they're not just kind of maybe small subsidies, small targeted incentives, small bits of support to like extend that route, that 1 kilometer, so you're actually hitting the main hospital. Make a cross route so people who need to get to a hospital, so they may well be, sick, don't need to walk a kilometer through downtown in order to make the connection. These kind of small adjustments to systems that aren't calling for like wholesale replacement or, again, fantasizing that with like one BRT line, we fixed everything, but are understanding that there are gaps and not everything can be like hung on these poor minibuses that are supposed to like move cities of 10 million people, 10 million people. Right, but that are often very, very sprawling and have very poor land use, kind of integration and mixed use. And sort of maybe keep that in mind as you're positioning new facilities. So I think that would be my sort of summary on that. Maybe not terribly optimistic.
Thanks, Tamara. Diego.
Thanks, Kate, for your comments. They are really insightful and they make us think about this. I would say, well, first, I want to point out what you mentioned before, that it's really important to think about different metropolitan contexts and that sometimes we are used to work on accessibility only looking at big metropolis, or maybe not that big, but central ones, capital cities, and we think we have like an assumption, maybe I'm wrong, but I feel that that you have accessibility problems only in big cities. And this is not the case. I mean, there is a whole space between rural areas and big cities that I think the literature has not addressed enough. And I think that's a pretty big problem, that public transport officials shouldn't take it for granted that in small cities you don't have mobility issues, because everyone has a motorcycle and you can walk and there is no problem. First, because some cities are not that small, and second, because sometimes there is a suburban logic, but not a suburban logic with a metropolitan pattern, but with a very low dense urban pattern. And this is a very important issue, a serious issue. I will say, it's great that you bring the sectorial approach. I think that's very important, because sometimes every time we talk about mobility, we say, well, policy implications, we should make transportation planning and urban planning dialogue, and that's the solution. And sometimes you can't even think about that because it is impossible. But for this case, this could be pretty contradictory, but for the settings in our study, one of the problems is that you really have a starting point problem of urban development that you won't be able to mitigate with transport. And that, I think, it's another type of problem. When we present these results, we have some public officials, and it was like a discussion, something like, okay, so these cities, we have to erase them, and that's it. We can't do anything about this. And of course, it was like a sketch, but to some extent, there is a policy tension underneath. And I think this is the great problem. The state, we have informal issues and problems with transport network. For Uruguay, we didn't have a public transport network drawn for a geographical information system. We had to do that for this pressure. And there you see that transportation, public transport in particular, is not a priority. And sometimes it could make the difference. Maybe I have an example, not from, it is from this study, but the next step, a more qualitative one. We had two cities close one to another, one like 10 kilometers or 20. And the teenagers that had to do to secondary school, they couldn't make it. One of them has a secondary school and the other didn't. But the public transport went through at some time, but if they want to go to the high school, they should sleep in the other city because the bus wouldn't go back at the time of the exit. So that is the type of problems that, to be honest, when we talk with buses companies and they told us how much it cost to have that service that was inadequate and how much it would cost to have the other service, you see, well, you need public investment there. And that, I mean, you have to give priority to public transport and not to assume that public transport in small cities is not a deal. It's not a problem. I think that's, I mean, it's not a policy implication by itself, but it's like a previous step. We are in a -1 level for this type of settings, I think. I will not take more time because
thank you, Diego.
Forever about this.
Santiago.
Okay, thank you, Kate, for the comments. I agree with you, with Diego, with Tamara, that for example, a lot of the review articles that we see are based on large cities like Bogota, for example. We have in Colombia, we have a lot of research articles with Bogota as the case study. They use BRT, aerial cable system, private vehicles, bicycles, and we are trying to put the eye and the attention on other geographies in Colombia. We have or we had some issues with the data because, for example, we could go directly with the government to obtain, for example, the road networks or the speeds or data about cycling, but we decide only to use accessible data, access data on the internet. For example, OpenStreetMap, Google Maps, Landsat data, in order to give the opportunity to other cities in the world to replicate the investigation, because we know that sometimes it's difficult to obtain, especially data about the road network, maybe about the speed, and I think that in terms on equity, that is important too. We read a lot of papers and research that are impossible to replicate in other contexts. We don't have the data, we don't have the programs. If you use, for example, a specific program that that you need to pay, that it is impossible for some people maybe to obtain the license. So for us, what the access to the data is very important. The access to the information, the codes will be available when we finish the peer review, the peer review or the article is published. And we found some interesting things about the equity inside the cities. For example, Cartagena is a very good example about equity. Why there the people with high income levels of money or something like that are allocated in the zones with lowest accessibility. That is not common in accessibility results. I think that is because of the kind of metric that we are using. We are using a geographic accessibility measure that is different than integral or the relative accessibility or the community opportunity accessibility. So that is a reason that we need to put the eye or the attention to compare these kind of results with the other ones that we have. On the other hand, we want to go in deep in the results about cycling, for example, because the most common cities that we are analyzing in cycling are cities are flat cities without the slopes, without climb. So we have very different topographies in Colombia. We have the Andes Mountains, and we have the Andes Mountains in a lot of cities in Latin America. So we could have other approaches about cycling, and comparing with private vehicle is very important because we are trying to conduct a modal shift from private vehicles to cycling, for example. And that is something that in accessibility some researchers are doing in recent years. For example, in Bogota, again, they are conducting research about modal shift from private vehicles to cycling. So that is something that we are trying to do and to continue in the research.
Thank you, Santiago. Luis Gabriel.
Well, thank you very much. I'll address Kate's questions and 3 other points. First, I want to point out that the platform that we use, which I'll share in the chat, is interactive, and it's we've made it available for the results we have already published. So what we have in mind, and that a key element here, is that we don't tell people what to do. We allow decision makers to reach their own conclusions. They can go and look at the data speaks to them, and they come to their own conclusions. They can change the thresholds from 15 minutes to 20 minutes. Oh boy, you burned yourself. So it allows to have people to reach those conclusions. I think that's very important in terms of knowledge translation. We think that that this can be replicated and used in other services, and I was so happy to see that Tamara, about the issue of education, because I think you could be doing the same with education. You could be painting the schools and looking at when traffic builds up, how it affects the kids that have to get to the place. You could use it with emergency services response. You could use it with family protection units and so on. So it could be applied in other ways. Addressing Kate's questions, which is the biggest inequity you need to address, I think it's the economic one. I think it's very clear from what we found in Cali, at least that the people that are being left out are the poorest. In public health, that's called the inverse care law, when the people that are the poorest have to pay more to get to the service. And I think that was for us. What was not captured? I think I would highlight a couple of elements. One, we used examples where either the services were very concentrated, so you could go to one service or the one next to it, or emergencies where there's an obligation to receive the patients regardless of their insurance coverage. But if you are going to expand this, you need to put another layer, and that is what kind of insurance company is covering this person, so that they can match. And then you say, well, it looks like this, but actually the reality is slightly different because it turns out that they cannot go to that hospital, but to that one. The other element that's not captured is that people don't go to the hospital which has the shortest travel time always, for valid or invalid reasons. For valid reasons is, for example, because they have a preference. There's a reputation of the center, or because for invalid reasons, sometimes the person driving them has a perverse incentive to take them to a different place. And that's the case. And ambulances actually don't work well in Cali for this. And one of the reasons is corruption. But they're addressing it now. But people have to go in the car usually. So that's matches the examples that we used. Those are the two elements we think we're missing. And I want to touch on what Diego brought up of urban versus rural, because I agree with him. Well, sometimes, in my view, and what I've seen is, basically, if you're looking at rural environments, the impact of traffic is far less. And probably having the picture, the static picture, is going to give you a good enough idea, and that's much easier to get. However, when there's traffic congestion, that changes. And that could be in urban or rural environments, but it's more frequent in urban environments. However, I want to point out that this study that we did, basically, it's unfunded. The only thing we had to really pay for was for downloading the data of travel times for everybody. We chipped in and we were able to download that data. It's accessible, could be done by a city very easily. We're talking about here of our own pocket money that we were using to get the data. But if you have the data and you think of metropolis, like could be Cali itself, but Bogota or Guayaquil, so many other cities in Latin America, Buenos Aires, you could include the broader area because people that are living in the outskirts of the city also use the city service. So we were trying to prove that it can be done. And I think we've proved it. And we are about to publish the data of the impact of adding new services. And it's dramatic. In cities like Cali, adding one new service doubles the accessibility that you have at rush hour. And with two services, basically everybody will be able to make it. And that's incredible. Of course, adding a tertiary care level hospital is not a cheap endeavor, but it has shown that it cannot be added where all the other ones are. And what has happened traditionally is that when decisions are made, they say, well, build it in this area because people are used to going there. But we didn't have this data. And now that we have this data, we say, well, people might be used, but we are really hurting the people that are being left out. And I think that's the key element that using these kind of indicators on dynamic accessibility is going to make a difference. And putting them in the hands of decision makers. For example, Cali is now changing its whole administrative structure. So they're going to have now 6 localities. This is the moment for these people to use this and fight for the right to have services within reach.
Thank you, Luis. Thank you, everybody. I think that both the presentations and the comments and the responses have been really interesting. I think there's still many aspects that we need to, like as Kate pointed out, there are many different aspects that need to be addressed to understand what are the biggest inequities, but also to start thinking about action to those inequities. As Kate mentioned too, it was really interesting to see that all the papers were speaking about like policy impact in different scales. I think that research that informed policy is like the way forward. And I will say that the comparative nature of the work, it's really interesting, but also the biggest challenge in terms of understanding what are the implications methodologically for that. And one aspect that I would like to have more time to discuss is whether because we were looking at accessibility, if you look for them in terms of the transport, like if you look in terms of the transport, then it's improving the network of transport. But if you look at it from the perspective of the services, it's improving the services, but there is still a lot of questions about why don't we try to mix both and start thinking in measures that reduce the traffic so we increment accessibility. Of course, in the context of Colombia that I know really well, the location of services, it's really poor in poor areas. So that's an aspect that needs to be, of course, taken into account. But maybe in other contexts, we also need to think about what are the necessary measures to reduce traffic to increase as another way to also increase accessibility. I will have to ask if someone from our audience wants to have a question, someone wants to have a final comment, or otherwise I will be Lucila, please.
Hi everyone. Congratulations on all the fantastic work. Well, I just want to do a brief comment about what Santiago said about the restriction that the availability of data has a very important impact in the kind of analysis that you can make in different cities, especially the smaller ones. That's one thing that I want to thank him for bringing it here to the debate, because it's very important. And I have a question for Tamara, because as they measure accessibility by foot, so I wanted to know if they address something about the walking conditions, let's say, the walkability issues that may present and be a challenge in addressing the real accessibility that people may have to health services or to education. Well, that's it. Thank you.
Yeah, no, I wish we had better data on where we could sort of, modulate, give some estimation of walking friction or walking speed. I think it'd be interesting to develop. Cycling has a little bit of this index, right? Like how stressful or cyclable a given street is regardless of speed. We don't really have that data at any rate for walking for these cities to produce that kind of map. There's been an increasing amount of qualitative work on this, particularly for African cities. The results of the qualitative work are that it is terrible. What we can do is sort of we can put in kind of low walking speeds as our best way of estimating that to kind of add friction to this accessibility map. But for this analysis, no, we just don't have granular enough data to really assess that.
Thank you. Thank you for the answer.
Any other question? Well, I think there's no more questions today, so I would like to close the panel, thanking everyone that was here today. The presenters, Kate, thank you so much for your participation. We really appreciate that you accepted to be the commentator. To all the audience, and well, we are going to be editing this, the videos and posting them in the Intellect website. And I think that is really important to bring the different aspects that you mentioned to continue advancing studies in accessibility, which I think every day is more evident that is a really like a wide range of different issues that need to be looked at, from looking at accessibility per person, accessibility per city, like about the age the accessibility is different on a personal, individual level, but it's also different in every city, the scales of the city, how we use comparative work. So I think this is just a topic that is just starting, and both from the quantitative point of view and qualitative point of view will need a lot of further development. What I've find most important, as was mentioned here, is that this research is already looking into informed policymaking, which is where it really matters at the end. So thank you everyone for this panel, and I hope you enjoy the rest of the panels in this seminar.
Well, thank you very much. Thank you for the excellent moderation and questions.
Bye-bye.
Bye-bye.
Hi, thanks.